Acute anal fissures. In this segment, we'll explore acute anal fissures, common yet painful tears in the anal mucosa. We'll dive into their pathophysiology, symptoms, and evidence-based treatment. An anal fissure is a linear tear in the mucosa of the anal canal, typically located at the posterior midline due to reduced blood flow in this area. The condition arises from trauma during defecation, usually caused by hard stools or excessive straining. The mechanism of injury. The mucosal tear exposes the internal and anal sphincter muscle, triggering a cycle of pain and spasm. This spasm reduces blood flow to the fissure, delaying healing and perpetuating symptoms. Acute anal fissures can become chronic. If left untreated, the fissure may become chronic, leading to fibrotic tissue formation and the development of sentinel skin tags. Chronic fissures are more challenging to treat and may require surgical intervention. Patients with acute anal fissures present with classic symptoms that significantly impact their quality of life. Their main complaints are either pain or bleeding. The pain usually is sharp, agonizing anal pain during defecation, which subsides after the bowel movement. The bleeding is bright red bleeding, usually seen as streaks on the stool or toilet paper. Associated symptoms include constipation due to fear of defecation and perineal itching. The pain is often described as a tearing or burning sensation localized to the anal verge. In severe cases, pain may radiate to nearby regions like the perineum or genitalia due to the similar dermatomes, which is sacral nerve S2, 3, and 4, or the pudendal nerve. Diagnosis is usually clinical and relies on a detailed history and physical examination. During inspection, a tear or oscillation is visible at the anal verge, usually posterior. In chronic cases, sentinel skin tags and induration may be noted. Digital rectal exams are often avoided in acute fissures due to the pain, but may confirm sphincter spasm or rule out other pathologies. The treatment of acute anal fissures focuses on breaking the cycle of pain, sphincter spasm, and delayed healing. The primary goals are to relieve symptoms, promote healing, and prevent recurrence. The first-line treatment includes conservative measures, topical medications, and dietary modification. The first-line treatment includes conservative measures, topical medications, and dietary modification. Symptomatic relief is initiated by warm sitz bath with betadine solution 3 times daily or after defecation for 15 minutes. It helps relaxes the sphincter and promote blood flow. Topical pain relievers like lignocaine ointment numb the area, reducing pain during defecation, and are given twice daily. For muscle relaxation, we use topical GTN cream or glyceryl trinitrate. It's a nitrate-based ointment that reduces internal sphincter spasm by relaxing smooth muscle. This enhances blood flow to the fissure and speeds up healing. Apply it twice daily, but watch out for the side effects like headaches, which are very common with nitrate. Stool softening options. We are terrified of constipation because constipation is the primary cause and must be treated aggressively. Therefore, we use bulk-forming laxative. We use lactulose syrup, 15 milliliters, twice or maybe 3 times daily. It helps in retaining water in stool and softening it. Bran tablets. We use 2 tablets 3 times daily with the addition of intaking excessive water and adding fiber to the diet to increase stool bulk. Patient should aim for soft, easy to pass stools to avoid further trauma to the fissure. General lifestyle modifications. Lifestyle modifications are critical to ensure long-term healing and prevent recurrence. Therefore, we advise patients to go for dietary change, increase the fiber intake through fruits, vegetables, and whole grains. Drink plenty of water, at least 2 to 3 liters daily to maintain hydration and stool consistency. We encourage patients to avoid straining during bowel movements. We advise them to respond promptly to the urge to defecate to prevent stool hardening. Most acute anal fissures heal within conservative treatment, but if symptoms persist for more than 6 to 8 weeks, the fissure may have become chronic and require surgical intervention. Piles are swollen and inflamed vascular structures in the anal canal. They are part of normal anatomy, but when they become enlarged, they cause symptoms. Hemorrhoids occur when the venous cushions in the rectum and anus have become engorged and symptomatic. They are categorized as internal or external. This depends on the dentate line, whether it's above the dentate line, that's internal, below the dentate line, that's external. Piles affect people of all ages, but they are most common in adults aged 45 to 65. Risk factors include constipation, prolonged sitting, pregnancy, obesity, low fiber diet. The clinical presentation depends on whether the hemorrhoids are internal or external. Internal hemorrhoids, they are most common and they mostly present with painless, bright red bleeding, typically seen on toilet paper or the stool surface. Prolapse during defecation, which may reduce spontaneously or require manual reduction. Perianal itching and discomfort. External hemorrhoids, however, present with painful swelling near the anal verge, especially if thrombosed, localized discomfort, and irritation as well. We classify internal hemorrhoids according to their severity, to grades, grade 1, 2, 3, and 4. Grade 1, there is no prolapse, only bleeding is noted. Grade 2, prolapse with defecation but reduces spontaneously. Grade 3, prolapse with defecation and requires manual reduction. Grade 4, irreducible prolapse with potential strangulation or thrombosis. We require proctoscopy, where it's essential for visualizing internal hemorrhoids and ruling out other conditions like rectal cancer. Management depends on the severity and grade of the hemorrhoids, ranging from the conservative measures to surgical interventions. The conservative treatment that we use for mild cases or early grade hemorrhoids, lifestyle and dietary changes are key. The lifestyle modifications, we encourage patients to have a high fiber diet with foods like fruits, vegetables, and whole grains. We increase fluid intake to 2 to 3 liters of water daily. We advise against straining during defecation. Symptomatic relief, we use a warm sitz bath with betaine solution 2 to 3 times daily, especially after defecation, to reduce swelling and relieve irritation. We might use any topical pain relief with lignocaine ointment to reduce discomfort. To soft, we use bulk laxatives like the lactulose syrup or the brand tablets that were used in the treatment of acute anal fissure. The medical treatment for uncomplicated, especially first or second degree hemorrhoids, medication can alleviate the symptom. We use decongestion or local venous decongestants like Daflon 500 mg. Daflon is a flavonoid that improves venous tone and reduces capillary permeability. It is particularly effective for internal hemorrhoids and should be taken as prescribed for 7 to 10 days. Benign prostatic hyperplasia. Benign prostatic hyperplasia, or BPH, is a non-cancerous enlargement of the prostate gland that occurs with age. It affects up to 50% of men by the age of 50 and up to 80% of men by the age of 80. BPH is characterized by hyperplasia of the prostate stromal and epithelial cells, resulting in gland enlargement and subsequent compression of the urethra. The symptoms of BPH are classified into 2 categories, either obstructive or irritative symptoms. Obstructive symptoms includes difficulty in the starting of urination, which is hesitancy, weak or intermittent urine stream, incomplete bladder emptying and post-void dribbling, prolonged urination and straining to void. Irritative symptoms include increased frequency of urination, especially at night, nocturia, urgent to urinate, burning sensation during urination, and in severe cases, BPH may cause acute urinary retention or hematuria due to stented bladder veins. A focused clinical examination is essential to evaluate BPH. We use digital rectal examination, where the prostate is palpated through the rectal wall. In BPH, the prostate feels soft, symmetrical, smooth, with a preserved central sulcus. If the prostate is hard, irregular, or asymmetric, prostate cancer must be ruled out. We also use diagnostic investigations to rule out other conditions and to confirm the diagnosis of BPH. For example, we use PSA or prostate-specific antigen. PSA levels are measured to screen for prostate cancer. Mild elevation may occur in BPH but must be interpreted cautiously. We use transrectal ultrasound, used to assess prostate size and structure. We also require urine analysis to rule out any urinary tract infection and hematuria. We might order kidney function tests, which are blood urea nitrogen and serum creatinine levels, to assess for secondary renal impairment due to bladder outlet obstruction. The treatment of BPH focuses on relieving symptoms, improving quality of life, and preventing complications like urinary retention or renal damage. Lifestyle modifications include reduced fluid intake, especially in the evening, to minimize nocturia, limit caffeine and alcohol, which can irritate the bladder, encourage regular physical activity to improve urinary flow. For symptomatic BPH, medications are the first-line treatment, and most commonly we use alpha blockers or tamsulosin 0.4 milligrams once daily for 14 days. This medication relaxes smooth muscles in the prostate and bladder neck, reducing dynamic obstruction and improving urine flow. Tamsulosin is well tolerated, with common side effects being dizziness or retrograde ejaculation. Treatment duration typically starts at 14 days with follow-up to assess response. We might use 5-alpha reductase inhibitors, for example finasteride. These drugs reduce the size of the prostate by inhibiting DHT production. They are most effective in men with significantly enlarged prostate. Onset of action is slow, taking up to 6 months to show maximum benefit. We might use combination therapy, combining an alpha blocker with a 5-alpha reductase inhibitor is more effective for men with severe symptoms and larger prostates. If medications fail or complications develop, surgical intervention is usually considered.